What I presented today were the preliminary data from the KEYNOTE-52 trial, which is a phase 2 trial of pembrolizumab as first-line therapy in cisplatin-ineligible patients with advanced urothelial cancer. What we presented was the interim analysis of the first 100 patients. So what we observed in the first 100 patients was that the objective response rate was 24% and the complete response rate was 6%. Additionally, another major objective of the trial was to define a PD-L1 expression cut point to help define for us who are the patients that are most likely to respond to treatment. This was described in the protocol as something called combined positive score. This was measured as the total percentage of tumor cells as well as immune cells that stained positive for PD-L1 over the total tumor cells in the specimen. What we found in the study is that at a cutoff of roughly 10%, which means 10% expression or greater, that we enriched greatly for responses with pembrolizumab. In fact, patients who had 10% or greater expression had a 37% response rate, a 13% complete response rate, and also a high rate of stable disease, suggesting that PD-L1 expression at a level of 10% or greater truly enriches for patients who are most likely to respond to pembrolizumab. So this trial is set in the first-line setting, and this analysis is on the first 100 patients. Key observations are the response rate and the biomarker cutoff. However, this will need to be validated in the overall study population of 374 patients. Coupled with the data from atezolizumab, what we are seeing is that the responses are very similar and that these do make a strong argument for first-line immunotherapy, at least in a subset of patients with metastatic urothelial cancer. The additional question in the adjuvant setting is one that is currently being actively answered with multiple randomized phase 3 trials in the adjuvant setting, and we will try to see if immunotherapy with PD-1 or PD-L1 blocking antibodies also improve risk of recurrence and survival in the adjuvant setting. Right. So one of the major areas that we're moving to, so now we've seen data from trials of second-line immunotherapy, we've seen now 2 trials of first-line immunotherapy. There are ongoing trials of adjuvant immunotherapy after surgery to remove high-risk bladder cancer. The next step is to see if immunotherapy can augment current standards of care in the primary disease setting, which means for patients perhaps who are being treated with chemotherapy and radiation, is there a role for immunotherapy in combination with that? And we have studies that are ongoing looking at that question as well.